let's say you're an emergency medicine doctor and a 32-year-old woman, G2P1 at 18 weeks gestation, presents to your emergency room with a chief complaint of fever, lower abdominal pain, and vaginal discharge for the last day and a half. In triage, her temperature is 103.5, her heart rate is 122, her blood pressure is 80/60, she's satting 88% on room air, her respiratory rate is 25. She's very confused and delirious. She has 2 IVs placed, started on broad-spectrum antibiotics and IV fluids, and taken to the back. On exam, you notice tenderness over the uterine fundus. On vaginal exam, she has purulent, foul-smelling vaginal discharge. Ultrasound shows severe oligohydramnios and a fetus with minimal movements but still has heart tones. Her labs are notable for a white blood cell count of 28,000. Her platelets are 85. Her creatinine is 1.6. Her INR is 1.5. Her lactic acid is 4.5. She is immediately admitted to the ICU for intensive monitoring. She has a fetal monitor placed. She has a central line placed to start vasopressors. Her blood cultures return back with polymicrobial sepsis. She has E. coli and group B streptococcus bacteremia. Despite being on broad-spectrum antibiotics and vasopressors, her blood pressure continues to drop. Now her labs are worsening. She looks like developing DIC. Her INR keeps climbing. Her platelets keep falling. She's having oozing from her IV sites and now having vaginal bleeding as well. She is going into oliguric renal failure. She stops urinating, and a dialysis catheter is placed so that she can be started on dialysis. The fetal heart tones are still present. Her blood pressure continues to drop despite up titration of her vasopressors. After about a day of this, her fetal heart tones finally stop, and doctors go to evacuate the pregnancy. However, because of the delay in care, she's been in the hospital for about a day and a half. The sepsis has taken its toll. She is in full-blown DIC, and the procedure causes a complication of bleeding, and she develops hemorrhagic septic shock, and despite their best efforts, the patient dies. So at what point in her clinical course would you, as a doctor, be comfortable performing an abortion? With the revocation of this EMTALA law, when would you feel comfortable doing this? At what point during this course that I just told you would you feel comfortable performing an abortion to save the patient's life and to protect yourself from legal ramifications? Would love to hear your response.